welcome. So we've now got 6 consultants and no trainees. I couldn't make it, but Danny and I had geared this talk towards the registrars. What do you think, Danny? It's still reasonably useful.
Yeah, I think so. I think, just going through the video, I mean, obviously we'd like to go back and, go through cases together like we did before, but I guess if we just go through, I recorded a lab colleague I did the other day. I thought we could, go through that and talk about, the pitfalls and what I did wrong and all that. We can critique my skills. Would that be useful, guys, or what do you think?
I think that will be very useful. Sort of. Let's hear from you. What you prefer.
Okay. All right.
I think, Mike, have you got some advanced cases that you're going to present at the end?
No, it's just to discuss with the registrars the difficult cases that we see and how to sort of go around them with the open technique.
Yeah. Can I ask a question? If you had a really difficult gallbladder where Callow's triangle is just concrete, so you decide to do a subtotal cholecystectomy, and as they often do, they get a bit of a bile leak. What do you do then?
Never had to do a subtotal. I haven't done so much cases to do end up with doing one.
Uh-huh.
Yeah.
But
usually I would just dissect retrograde and then find a way, easily find my way around anterograde, retrograde from posteriorly and slowly release, sticking closely to the gallbladder. Usually with the recurrent cholecystitis, when I find the peritoneum would be there's lots of scarring around there, but I've never had to do a subtotal.
Wouldn't you just wait, Danny? Just leave a drain in and wait?
That's what I was asking, because here we'd send it for an ARCP, but you don't have that option, really, do you? So yeah, I guess you just leave the drain and wait. But yeah. All right. Can I share my screen, Gary? Is that possible?
Yeah. Okay. Hang on a sec. Okay, you're good to go.
Okay. All righty. Let me start here. Hold on. Drop that. So I've got a bit of a video, but I thought at the beginning we'd talk a bit about the technique of how to put a Hassan port in, because that's the start of any lap operation. And so I remember, so Rooney, when I remember the last time I was there, we were using those reusable ports. Are we still using those? You're on mute, Rooney.
Unmute, Rooney.
Okay, sorry. Yeah, I think they're still there. I think the main problem we have is, with the forceps.
But I just remember with those ports, the trocars were really, really sharp. So I guess you just got to be really careful when you put in those ports, especially the first one. So basically, I don't have a video of this, unfortunately, but the technique I like to use is basically dissecting down onto where the cicatrix meets the fascia, and making your incision across the cicatrix and fascia, and just slowly entering through that point. So basically, I make a longitudinal incision, dissect out the cicatrix, I pick it up with a Moynihan hen or a little wood, dissect out where the fascia meets that cicatrix, and make your incision, and then bluntly enter into into the abdominal cavity with an archer clip. And I think if you do it that way, you're less likely to damage anything underneath.
Hey, Danny, we lost your volume.
Is that better?
No, that's better.
Yeah, sorry. Yeah, okay. So the point, let me just switch to my phone because I think my internet's no good. Just give me 1 sec. Sorry about this, guys. Okay, give me 1 second. If I drop out for a second, it'll only be a moment. I promise. All right, can you hear me now?
Yep.
Okay, all right, no worries. So once you've got that port in, let me just see if I can start playing my video. Where is it now? Hold on. All right, can everyone see that?
Yep.
Yep. Okay, so
You've got the white box in front of it.
the white box.
Yeah, you've got your folders in front of it. Just close the folder.
Where's the folder? Hold on.
Oh, it's okay. No, we're good. You're good.
You all right?
Yep.
Sorry. Okay. All right. So this is just basically like literally how I do it. So I've put the Hassan port in. We put the camera in. Now, so I put I use 5mm ports. But if you haven't got a 5mm camera, you're going to have to put a 10mm port somewhere because you're not going to be able to take the gallbladder out through a 5mm port. But usually what I do is I'll switch at the end to a 5mm camera and take the gallbladder out through the Hassan port in the umbilicus. So what I'm aiming to do now is to put the first port just to the right of the falciform ligament, and it's just below the xiphisternum. So that's the first port there, and it's under vision, as you can see. We have these balloon ports, so we don't have to worry about them falling out. But, you know, that's a luxury you don't really need. And then there's two further ones in the right upper quadrant. And one port there is for the assistant. So the most lateral port is for the assistant, and the other two ports are for me to operate with. And so let me just press pause here. So that's, oh, sorry. Let me just go back a touch. Sorry, guys. Okay, so that's the Hassan port with the gas going into it. This is the xiphisternum just here, and that was the first port we saw going in, and these are the other two ports. So the way I've got the room set up, this is the head of the patient up here. You can just see where the sac is standing, so next to the head on the right side. I have a quiver in the right upper quadrant where I'm going to put the graspers and whatever I'm not using in and out of. And I try and keep all my wiring sort of at the top of the patient, try and keep them out of the way. So whether you run it this way or you run it this way, it doesn't really matter, but just try not to have it going through your surgical field. All right, so now the first thing we're going to do is dissect out Callow's triangle. So I'll show you this video now. So as you know, Callow's triangle is between the liver, the cystic duct, and the common hepatic duct. So she's got some adhesions because she's had recurrent attacks. So the first thing we do is take those down. She's also got a bit of a fatty liver, so you just got to be a bit careful when taking the adhesions and when retracting the liver. And in fact, I had a bit of a slight liver injury from the grasper while doing the cholangiogram, which I'll show you a bit later on. So you can see she's got a few adhesions there. Now, this is sped up a little bit. I'm not this quick. I'm not that talented. But I thought you don't want to watch me going at my pace. Now, this here is the sulcus of Rouvier. So as long as our dissection is above that, as long as we're not dissecting down here too much, we're well away from the bile duct. So that's why I start on the posterior side above the sulcus, and then I'll work my way around the front. And it's just peritoneum. I'm just doing one layer at a time, just a small amount, put the hook in, lift it up, make sure there's nothing in there. My assistant is retracting the fundus of the gallbladder up over the liver to give me a bit of retraction, and I'm just moving Hartmann's pouch around. Just like, as you can see, lifting it up, just to make sure there's nothing in there, and just slowly buzzing until I find cystic duct and cystic artery. So there's nothing in that, so we'll burn that away. And then there's nothing in that, so slow, just going one step at a time. And this really is worth doing slowly, because an injury here will sort of ruin this operation. So you want to take your time here, and just go one step at a time. So that's peritoneum. And there's a little bit of fat at the back there, so we're working our way around. Some people like to use a spatula. I find the hook allows me to lift up to see what's in the tissue. But whatever you're comfortable with, and I guess whatever you have, is what you'll use. So just lifting up, and that's gone around there. So that's cystic duct, and I'm just going to free it up. And you want to see it going into the gallbladder to make sure that it's not a very short bile duct that's going to tilt up and come across around there. So we basically have a view of it going into the Hartmann's pouch, so we're quite comfortable that it's safe. That's cystic duct, and next to it will be probably the anterior branch of the cystic artery. So just got to be a bit careful. All right. Now, does anyone want to raise any questions or points during that? Any questions? All good. Gary, you got any comments you want to make?
Very nice.
Okay, so now the cholangiogram, which I'm going to show now, I guess is not really essential. So I mean, it comes down to what resources you have. Like if you don't have II, and you don't have the cholangio catheters and all that sort of stuff, then it's probably not really necessary, especially if the patient's LFTs are normal. It's unlikely they'll have a deranged cholangiogram and have completely normal LFTs. Now, this lady had a slightly elevated bilirubin, and so I'll show you her cholangiogram. Essentially, first thing we do is try and put a clip up as high as we can on the cystic duct, close to Hartmann's pouch, so that we've got room to clip below it after we've done the cholangiogram. Now, if it's safe and easy, you can clip the artery. So I've attempted to do this at this stage, but then I found it was, I wasn't able to get behind it properly, and I was worried that there was going to be a posterior branch there. So I stopped. I said, I'll come back and do it once I've divided the cystic duct. So now I'm going to bring the scissors, and you can see, like, this is what I'm talking about. She has quite a fatty liver. It's quite stiff. So as we go in, I'm going to milk the bile and any sludge, and there's a bit of sludge there. So I just milked it until it came back nice and clear like that. And now I'm going to introduce, using an Olsen Reddick, which is basically a forceps that has a lumen for this catheter to go into. And this is primed with saline. I'm going to get the nurse to give it a bit of a squirt just to make sure it is primed, clean the area so so there's nothing in there, and it feeds in. Now, there are often valves along here, so it'll only go in so far, but it doesn't have to go in a long way. It just has to go in enough that when you clamp it down and you squirt, nothing comes out. So now we're going to do the cholangiogram. And so I've got a photo of, okay, so here's the photo. So the radiographer has got the C-arm. This is the feet of the patient. This is the head of the patient. So my niece has taken this photo. I've used the epigastric port for the cholangiogram. People often like to put it through the right upper quadrant port using their left hand so that it goes in a bit straighter. Whatever's easier. Sometimes you have to be able to do both. And now I've got a lead gown that's just hanging on an IV pole, and I'm standing behind it. And we're about to do a cholangiogram. So this is the cholangiogram. So you can see the cystic duct is behind here. These are it's a spiral with valves in it. You can see the common bile duct here, common hepatic duct, and it divides into right and left common hepatics, and we've got an accessory right on this one. Now, in this lady, she appears to have some mobile stones at the bottom of her of her common bile duct, but it's not obstructing her common bile duct. That's why she's not jaundiced. So what I did after this is I gave her, I asked the anaesthetist to give her some buscopan, some hyoscine, and waited till we saw the tachycardia. And then I flushed it with about 100 mils of saline. And we repeated her cholangiogram. And I'll show you what it looks like. So now, because her end of her ampulla is relaxed, as I put the contrast in, it's not going to go into her upper biliary duct system, but that's okay. But you can see it's filled her duodenum, but unfortunately hasn't removed all of the stones. So here I have two options. You can try and do a transcystic exploration, but that's quite an ordeal, putting down a Roth basket and all the rest of it. So because it wasn't obstructed, what I've opted to do is I've just put an endoloop on her cystic duct so it doesn't leak. And I'm actually going to do a CT cholangiogram in about 10 days to 2 weeks to see if the stones spontaneously pass. Now, if they've passed, great. If they haven't passed, then I'm going to send her for an ERCP. But obviously I can do that because I have all of those options available. I guess if you don't have those options available, then you probably just wait and see. As long as it's not completely obstructed, then she should be okay. And if she becomes obstructed, then I guess you just have to go and fish those stones out, probably with an open bile duct exploration. Is that what you would do, Mike and Rooney, if you have an obstructed bile duct?
Yeah, well, yeah, Mike, go ahead.
Good. I mean, Rooney's had more experience with the bile exploration than me, so I think he should.
Yeah, I even, because gallbladder disease is not that common here, so I mean, now it's slowly becoming more common, but I've also have not much. I think the few cases that we have done in the past, we sort of either explore them through the cystic duct or through the near the ampulla, just through the duodenum.
Okay.
And that's very, very, very few cases. Yeah.
Okay. Yep. Okay. No worries. Now, can I just ask Rudy, when we did a few cases last time we were at in Honiara, I did an APR and we took the vessel using a self-made endoloop. If you were doing this laparoscopically, do you have a clip applier, or would you just use an endoloop and tie it off?
Well, I actually don't attempt any laparoscopy using any gallbladder using laparoscopy. So
yeah, because I guess what I was thinking is, so this next step we're dividing the we're going to divide the cystic duct and the cystic artery. So the cholangiogram done, and that's what I was talking about there. Sorry, let me just press pause for a second and go back. So as you can see, during the cholangiogram, as we let the liver come down, it was rubbing against the cholangiogram grasper, the ulceratic, and I've got a slight tear there. So you just got to be careful. These things can happen. Now, it's not a big deal. I'm just going to give that a bit of a buzz, but I guess you just got to be mindful that, especially in someone who's got a fatty liver, that it can be quite stiff and is easy to damage. So we've now taken the cholangiocath out, and I'm now going to clip this cystic artery, and cystic duct, and I'm going to then put an endoloop below it just to make sure it's airtight. Watertight. But I guess what I would do if I didn't have a clip applier is pass a tie around there, do an extracorporeal tie, and just tie it off. I guess that's all I could really do. And so this is just a man-made, thing that comes pre-made, but I guess you can make your own. Gary, do you want to go through how to make your own endo loop? Because you did it for me last time.
Yeah, look, basically it's a hangman's noose, so you can use any suture you've got, and basically, sorry, I'm not sure how well that, but you basically make 2 loops. You twirl it around and around and around, and pull that through the bottom one, and that's a hangman's noose. Okay, and that's all it is. And you put that suture through any device you have. Like here, there's a plastic endo loop knot pusher, so you can put it through that. And then you've got something stiff so that you direct it where you want it to go, and then you pull from the outside, you pull that end tight until it closes. So you could really use the plastic PDS endo loops if you've got some of them. Otherwise, I'm not really sure what you could use. Some of these graspers, you assemble them and there's a hollow bit to the grasper. So I don't know if they're actually long enough to reach. So I must admit, I haven't been in this situation where I've had to improvise. I've always used the existing PDS plastic knot pusher. So we use the first one, and then when we need more, we just make them out of Vicryl or PDS suture. So
I guess, Gary, in this situation, before you've divided the cystic duct, you could pass a tie around it, pull it back out through the port, and just do an extracorporeal knot and push the knot down.
Yeah,
I suppose you could do that just with your grasper.
Yep.
Yeah. Okay. All right. All right. Shall we carry on? So that's now the cystic duct taken care of. And now I'm just going to divide the cystic arteries and dissect the gallbladder off the gallbladder fossa. Now, this is the point I was making before. I was worried about a posterior branch, and if you just put your clamp in there, you may put a hole in that. And once you start getting bleeding, it becomes really difficult. Now this cystic artery was quite small, so I've left the 3 clips on the staying side, and I've just used my hook diathermy to burn it off the gallbladder. So that way I've got 3 remaining clips, and I just wanted to do that so I don't damage the artery at the back. And as you can see, there was an artery there, which I'm now going to clip as well. I guess the other thing you probably could do is spend a bit more time dissecting that out before you do your cholangiogram, but you just got to be mindful that it can be there. So I'll just divide that. And then again, just one strand at a time to make sure, you know, your anatomy is okay. We're pretty comfortable with anatomy because we did a cholangiogram, but you still got to just make sure you don't damage anything else while you're dissecting this off, because you've still got a bit of fat there. So I'm just going to do this one tiny bit at a time. Now, again, it's a little bit inflamed. It was a bit hard to hold on to. So I got my assistant a bit lower down on the gallbladder just to give me a bit more traction. And you're always safe being up high on the gallbladder and just going that way. And then after that, it's all pretty straightforward. Just going slowly, trying to make sure we get hemostasis. There's a bit of a mesentery, so I got pretty lucky there. And as I'm burning, I'm just pushing up against the gallbladder to, you know, try and not go into the liver as much as possible. Now, if the gallbladder is really, really inflamed, you can just leave a circle of gallbladder on the liver bed and just burn it, so that you don't damage that liver. What you don't want to do is enter into the liver too much, end up with a bile leak from like a duct of Lushka or something like that. And we just spent now just a fair bit of time ensuring that she's got adequate hemostasis, washing out any bile that may have spilt out, because that can cause a fair bit of pain, and just making sure it's nice and dry so we don't get a phone call in the middle of the night. So there's a little bit of bleeding, as you can see, just here. So I'm going to give that a buzz. And then what I thought there was a bit of bleeding here, and so I thought I'd give it a bit of a buzz. And then I panicked a bit and chickened out. So I thought I'd just watch it for a second and see what happens before I go put another clip on it. But I had the clip apply already, but it didn't look like it was going to be that easy to put a clip on it. So I changed it. Didn't look like it was bleeding to me at that stage, so I changed my mind. Thought sometimes you can make things worse while trying to make things better. So pulled out, came back to watch a bit more, and just spent enough time making sure that there was no active bleeding. And then so as you can see, it's not really bleeding or anything like that. So I thought I'd just leave well enough alone. And so what I do now, because I've got 3 5mm ports and only 1 12mm port, I'll change over the camera to a 5mm scope and introduce the endo catch through the Hassan and pull it out through there. But I'm quite happy. I'm going to give this one last cook, and then that's it. Then we're done. And then we're almost finished, I promise. I was a little bit pedantic with the washing, but I guess you can't wash too much, right? The other thing you want to be careful of is you don't lose the gallbladder, because that's always annoying, trying to find it if you let go of it. All right, just checking this bit. And then we're just switching over the camera. Probably should have cut this bit out. And we just fast forward a bit. So we use an endo catch, but you can't just use a glove for this. Just put a glove in and pop it in there and pull it out like that. And then we just watch as we take out the ports to make sure there's no bleeding. So these ports will come out now. Just put the camera in through here, make sure there's... So it looks pretty dry, and then just pull it out through the umbilicus. And then that's it. Any comments, questions, criticisms? Happy to take criticism.
It's a good case, Danny. Yeah. I think that you make inserting the cholangiogram catheter look easy. I struggle with that, and I often abandon the cholangiogram.
It's not that important. Like, if it doesn't go in easily, I'd abandon as well.
The other thing is, when you get the catheter up against those cystic valves, it won't irrigate, and then you end up with high pressure, and then it bursts, and you end up with retrograde fluid coming out of your insertion point. So yeah, I struggle with cholangiogram, and I've done a fair number of gallbladders. The other thing I would say is, just one strand of tissue at a time. It's a really delicate operation, and it's really nice when you finish this operation and there's no blood and there's no bile, and sort of no need for a drain.
Yeah.
And obviously you can't always do that, and that wasn't a that was clearly a diseased gallbladder. So it'll be interesting to see how she goes with that CBD stain.
Yeah.
I must admit, if it was me, I would probably refer her for an ERCP, but I don't think that's good medicine. I think that's just paranoid medicine. It's what we do here in Sydney.
Yeah.
and I think your approach of just waiting is a good one. She's not obstructed. You know, there's a 15% chance of pancreatitis just from an ERCP.
Yeah. So part of the decision making was her LFTs weren't that bad even the day after, and also her financial situation. I'd like to avoid an ERCP, so there's those factors. But I mean, what I offer, if she can avoid it, the great. Otherwise she'll have a ERCP.
I think you're giving a wrong message. I know in PNG and other places, you can't do an operative cholangiogram. I understand that for a number of reasons. But when you say that operative cholangiogram is not really necessary, and I think that's a very wrong message given to people. I mean, you try, and sometimes 90% of times you're able to get in, other times you can't. If you can't do it, that's okay. But giving a message saying operative cholangiogram is not necessary is not a right point. Now, for young fellows like you, I might give you my the 70s experience if you want. If you give me indulgent for a couple of minutes. Those days there was no ultrasound, there is no operative cholangiogram, and the diagnosis of a gallbladder made on what he calls a Graham's test. Am I taking too much, Gary, or just leave it?
No, I've never heard of a Graham's test.
Huh?
No, I've never heard of a Graham's test.
Yeah, well, it's a iron-based test. You give them all tablets overnight, and then you give them egg flips the next morning, and you take X-ray. If the dye comes through the gallbladder and to the duodenum, then it's not a gallbladder disease. If it doesn't work, then he's got acute cholecystitis, and you operate. When you operate, then you feel the common bile duct with your hand, standing on the left side, feel through the, what do you call it, the lesser sac opening, and feel it. If you feel some thickness or a stone or something, then you open the common bile duct and you put in dilator through the opening of the common bile duct, which makes sure that it enters the duodenum through the ampulla. Then you're satisfied. Then you put in a T-tube to close the common bile duct, and of course you remove the gallbladder by then. So I want to know, Rooney and others, if you open the common bile duct, you have facility to do the T-tube drainage, and how do you manage it?
To be honest, I have never had a situation in which I had to, a complicated situation in which you have a stone impacted in the gallbladder. But usually we just, if we have to put a T-tube, until there is no more drainage, then you pull it out and see what happens. So and it's a situation I dread.
So I remember when I was a surgical trainee, the surgeons, probably Santi's era, would go on about how, the red rubber T-tubes were wonderful, and now they're all silicon and they don't work and they don't cause a reaction, tissue reaction, but they got rid of the red rubber T-tubes. Now there's no discussion about that because it's all done, endoscopically, pretty much. Not all, but mostly in Australia it's done by gastroenterologists with ERCP. But just to qualify my statement about not always doing a cholangiogram, I think if you've got stones impacted in Hartmann's pouch and you've got like a dense fibrotic reaction, oftentimes the cystic duct is obliterated, it doesn't actually communicate. The other thing is you might have a normal gallbladder with stones in it, and the cystic duct is, 4 millimeters or 3 millimeters, and it's just not possible to get a 4 millimeter catheter into that cystic duct. And in that situation, I think it's reasonable, a pragmatic approach not to do a cholangiogram. Well, you've got no other choice, but you're not going to get a significant stone in the cystic duct in that situation. It's when you've got the big cystic duct like Danny had in his case, that you run the risk of leaving with an elevated bilirubin, that there is a real risk of missing the CBD stone.
Yeah, I agree, Gary. I think the point is it's worth trying to do a cholangiogram, but you don't do it at the expense of safety of the procedure. So if it's safe to do it, then do it, but you have to also know when is the time to pull out and not do it. So things you want to avoid is a really short cystic duct. So if you end up trying to do a cholangiogram and not being able to ligate just below it, then that's a disaster. And in a situation where, again, it's so small that you may inadvertently avulse the cystic duct and end up losing it if it retracts. That's the other reason I also didn't divide the cystic artery before the cystic duct, just in case, I accidentally divide the entire cystic duct. It's less likely to completely retract if the cystic artery is still intact. But yeah, I think it's worth trying to do a cholangiogram, but understanding its benefits and the limitations of your resources and abilities, and when not to do it.
Thanks, Danny. That was a great video, and thanks for all the effort you put into that. Mike, we might hand over to you, and just you can discuss some of your own experiences with advanced gallbladder pathology.
Yeah, so I've done a few of open ones, and the ones I did, similar to the ones in PNG, is our patients tend to present with complicated gallstones. They come in with recurrent. When they present, they have cholecystitis, and sometimes when they do present to the clinician, they get treated with antibiotics. That sort of settles. So they would have numerous presentations with acute cholecystitis, and so when we do prep them up, walk them up, and the ones we did last year, we did last year, they're both similar in that a lot of scarring around the gallbladder. The peritoneum would be scarred and thickened, and difficulty in dissecting around Carlos triangle. So one of the Douglas technique is, once you find it hard difficult there, he goes for the retrograde technique, and then look back at again around Carlos triangle, dissecting closely to the gallbladder. But it's usually the scarring is a lot more worse than the ones you saw there, Danny, from the recurrent infections. I think that's the ones we've showed. We've seen.
Yeah, I think, Mike, you're absolutely right. And an emergency gallbladder operation is a completely different ball game than a nice elective operation. Of course, I put up this nice elective case just to as an example, but
we lost you, Danny. I think your screen froze. Danny, your screen's frozen. Yeah, and the other thing is with laparoscopic surgery, definitely knowing when to convert to open and having a very low threshold. Unlike you, Mike, I'm a great fan of the fundus first dissection for a difficult gallbladder. So is that antegrade? I think it's antegrade.
Yeah.
Yeah.
Retrograde.
So fundus first, that would be antegrade?
Retrograde.
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 So particularly when the Hartmann's pouch is fibrotic and hard, that's where I think a subtotal cholecystectomy, where you leave a portion of the Hartmann's pouch, it's not a bad option. And I put a Rampley's on the fundus and start dissecting the fundus off the liver, and then just follow it down and even open up the gallbladder and pop my index finger in the gallbladder so that I can feel around my index finger and be sure that I'm sticking to the gallbladder and not getting into liver bed. But yeah, those difficult cases that you've mentioned, Michael, they absolutely have to be done open.
And with the we don't have the II machines and a good a bed that can do we can do the intraop cholangiogram. So what I do with what I have is just have a good preoperative imaging with the ultrasound. I tend to have a look with the ultrasound guy, looking at the gallbladder and looking at the bile duct and try and follow up the bile duct up into the looking at the hepatic ducts as well as following down the bile duct to the ampulla to see there's no other echogenicity that may suggest a stone distally. Apart from that, I've never had. I don't do the intraoperative cholangiogram. In PNG, what we did was for those that we can, with a couple of the ones that we did were very, very short cystic duct, and one was nearly an absent cystic duct, so we couldn't do a intraoperative cholangiogram. But there was one we did, a couple we did was with we stuck in using a T-tube, and then sort of flushing the dye along the T-tube, and then did the once we're happy, we did the cholecystectomy and left the T-tube there for a couple of days, looking at the drainage and eventually removing it.
Another. Go on.
Sorry. Yeah, but same as in PNG, they were doing mostly open. However, in 2018, Luke Anthony was there, so he was a PNG surgeon. I think he's back in Townsville now. So he was doing some lab chole, but not much to have a skills transfer to the lads up in Mosby.
Okay, what about your experience in Kiribati?
Yeah, sorry, I just had to unmute. Sorry, I had some internet connection problems. I was offline for almost 30 minutes, so I wasn't able to watch the videos Danny was showing. But yeah, we do almost like 4 to 6 open cholecystectomy a month. We have a high incidence of cholelithiasis in the Kiribati. It's one of the common operations we do here. We don't have laparoscopic facilities, so we only do the open cholecystectomy. Even if you have to explore the common bile duct, it's just open. We don't do ERCP or this. Yeah, we don't have the luxury of all this ERCP or the laparoscopic instruments. So all our cholecystectomies are open, like in PNG. So yeah, we've got we see a lot of difficult cases here. It's the ones we tend to operate are the ones with empyema or the ones with necrotic gallbladder, as the ones with really bad gallbladder. but just we don't do the ones who came in with symptoms, but we see a lot of cholelithiasis that we tend to defer operations because there are other more priorities like diabetic foot sepsis or amputations that take up our OT list, and we don't, you know, with our two operating here, we cannot. Some of these elective cases for, you know, the elective cholecystectomy, we tend, I mean, they come in with acute abdomen. So with cholecystitis, so it's a lot of our cholecystitis are difficult cholecystectomies here.
Echo, I know you do a lot of open surgery, you said. How do you manage the post-operative pain?
Yeah, we use you mean for post-op cholecystectomy?
Yeah.
I mean, we tend to use the IV morphine, pethidine. With the, I mean, yeah, but I think most of our cases we use the intravenous morphine and pethidine, and
You don't use any nerve block or anything like that?
not really. But I think after surgery, the anesthesia, sometimes they give the intercostal blocks. Some do in some of the cases.
Yep. Well, it's 5:58 by my clock, so we've got 2 minutes to wrap up. I just wanted to put up a promo for the next session, Rooney. We're expecting great things from you. So we've got Rooney and Charbel. Don't hold your breath. Charbel may not turn up. It might be you on your own, Rooney. So, yeah, this is a session not to miss. It's 5 to 6 p.m. Australian Eastern Standard Time, which is 6 to 7 p.m. in Honiara and 7 to 8 p.m. in Kiribati. So I'll send the link closer to the date. Now, I thought I'd just discuss the elephant in the room, and that is the absence of any trainees to this session. I think we had a few last session. That's not necessarily a bad thing. I don't know. What do you think, Rooney? Do you think these sessions are useful, or should we put a pause on them? Do you think they're useful if the trainees aren't attending?
I don't know, they're useful to me.
Okay, well, that's enough.
And I have been, you know, sort of reminding people about, so we have regular Zoom sessions with you and with the one organized by RAGS.
Yeah.
And I must say that I think the attendance of the registrar has been not very good in both Zoom sessions. Occasionally, Stallone and you know, Dr. Melia or other sort of consultant join in, but not very good from the others.
Oh, I think we'll just look. I'm very happy just having a chat with Mike and Akko and Rooney. So it's not an issue for me. I think it's just a good chance to catch up. It's just a question of whether it's you know, invading your own time constraints. You're a busy man, Rooney. You're now the Director of Medical Services. Is that right? Medical Superintendent again?
Well, I'm supervising, hopefully maybe for the next 2 more weeks.
Right. How did you go with the RACS surgeon that went over there for a year? Have they left already?
No, he didn't. No, he didn't come. He was actually Ugandan.
Right.
He's been like formally recruited,
Right.
But I think it's the process of getting him here, and it's and I think the weakness was on our part in
Okay.
getting him formally recruited, and now with the COVID and
Yeah.
so on. So I think we are not getting him, and now that we have Augustine, who is a Fiji graduate who's joined us, I think our load is not as great as it used to be, and you know, as soon as I think COVID is here, we'll probably sort of cease all you know, markedly reduce on our
Elective surgery.
elective cases. So
Yep.
yeah.
All righty. Any further comments from anyone, Santi?
No. It was a good session. Yeah.
No, very good session. Thanks, Danny. I really enjoyed the video.
Oh, anytime. Thanks for having me.
We'll see you in a month.
Okay, God bless. Bye-bye.
Thank you.